hope everybody can see the screen. Okay,
Yes.
great, thank you. So what I'm planning to talk about in the next 20 or less minutes is different ways that technology has played a role in the management, surgical management of hepatocellular carcinoma, but in general in liver surgery. And there are no disclosures. And the specific areas of technology that I would like to focus on are 3D printing, artificial intelligence, and a brief note about the use of HoloLens. Regarding 3D printing, this was an area started as a research project for us. And the idea was to combine the efforts of the medical school and the Department of Transplantation together with the engineering school, as well as some private enterprises, to basically create a research protocol where the patient would come with their CAT scan showing or MR showing a specific liver mass or more. And then through a portal created by the engineering school, this would be from radiology, the data would be transferred to them. So basically to digitize and incorporate into a 3D model, which then they would go into print, and this would be used for the surgery. And the whole goal, there were three things that we wanted to look at. One, whether these would be helpful in terms of education for students, for residents, for fellows. Two, whether it would help us provide a more informed consent for the patients if they could actually see the plan of the surgery, see the cancer. And then three, whether it actually helps in operative planning in terms of speed, accuracy, decreased complications, or whether it's just simply a fancy imaging method. And this is a work in progress, so we don't have the final results, but the way the 3D printing started for us, and again, this is not something that's the first time in the world, but for the limited resources that we have in Greece and the limited finance of public university, the importance of this, that it's an endeavor that was done purely by the schools in a very economically financial manner. And it has been, 3D printing has had different results that have been helpful in medicine, orthopedics, craniofacial surgery. And for the liver, the process included three stages. One, digitizing, which in the first stages had to be done by hand, basically going through every one of the slices. And you have to figure out which one is the liver tissue and which one is not the liver tissue, where are the vessels, whether it's an artery, vein, or bile duct. And eventually, the engineering school developed an algorithm that this could be done by the computer. You could get to the modeling and then the segmentation. And the initial results were very primitive. And then again, using technology, you would be able to do more of the scanning. And this was very important using a tablet with a lighter instrument. You could actually do that even in the OR if you need. So this slowly progressed over a couple of years to the ability to differentiate within the model between the portal vein and branches, the hepatic artery, the bile ducts, hepatic veins, and the mass. Then be able to print that. Also have to figure out what kind of color, what kind of parenchyma you want, because you want something that A, you can see through, and B, you can actually divide if need be, whether it's for practice. And again, this is work that is happening worldwide, and the whole idea is to be able to pinpoint where the tumor is, its location to structures that you want to preserve or you want to be careful about, and sometimes can even be the ability to see a mass can be even better than the CT. The way the printer used the fused deposition modeling, which essentially means layer by layer, and the costs, which is the interesting part, is actually can vary from a couple of $100 to one which is tens of thousands to some which are hundreds of thousands. But actually, in this range, you can do good work. So you don't need something very expensive. And of course, the differences have to do with how many colors they can use, what material they can use, the speed of the printer, the size of the end uh, result. And so it's something that takes time, it doesn't happen very quickly. And it has been helpful. There were situations such as the centrally located masked wing coral vein branches, which allowed us to be certainly more careful about the different dangers. The next steps, once you had the 3D printed model, was using augmented reality with it. And basically the ability to project this in space, anywhere in space, through the common use of a cell phone. And this is the biliary structures here. And the next step was actually projecting it in the operating room, where it could project the liver with the vessels, with the mass. And of course, this is using the picture from a cell phone. If you can do that there, you can do it on top of the actual liver. So you can have your maps, you can have your topography right there. As this is progressing, there are several challenges, and these have to do with facts such as a size difference, which is very small when you're talking about the smaller vessels, and the accuracy that you need, the cost, which can be a big factor, the material that you use, it has to be pliable, there can be a lot of different materials, and of course, everything is based on the quality of the initial image. And there's always a holy grail of things, which is artificial organs. And we're certainly a long way from being there. With the idea being, instead of using in the printer plastic or other type of thing, you use cells for your ink, use bio-ink essentially. And you put that on top of a scaffold, and especially if these cells are stem cells, then there's a lot of potential to what can happen. And there have been some initial studies which have shown creation of tissue, which can then, this is small amount of tissue, and the reason it's small amount has to do with the vessels and the neovascularization and how far you can go. So bioprinting certainly seems to be the future here. There are issues such as the ethics involved, and the goal is to have multiple cell layers, the same way that you're doing different layers with a printer, to have cell layers for that. Moving on to artificial intelligence and its potential in liver surgery. It's a word that artificial intelligence, we've been hearing more and more the last couple of years. It seems to be more present around us. And of course, the question, if we're going to put it in surgeons' terms, is what is it really? What is artificial intelligence and what can it do for us? And the idea is that having a machine do what a human can, however, with increased calculation and processing ability of the machine, this can allow you to have optimal use of the data, much better use of data, much better use of a much bigger volume of data, as well as having speech and pattern or picture recognition. So you start with the data, which you have to collect from many sources, and this is a challenge here. You're not talking about the data from a department of surgery. You're not talking about data from a hospital. You're not talking data about from a region. You're talking about data from all hospitals. You're talking about millions of data. That's when it really starts to have value and make a difference. And that's, of course, a challenge there. So you have to process this data, and using neuronal networks and different algorithms, you can actually get to the end result. So the machine is simulating human intelligence. It's not exactly the same thing, but it has the goal of performing the same calculations, just much faster and more accurate. So what are we talking about today? It's not something new. It's been here for several decades. The whole concept of artificial intelligence, dating back 1950s, algorithms, 1980s. And what has changed is the fact that two things. One, we have increased calculational ability. We have increased processing ability through computers. And two is the financial pressures involved. So applications of AI in surgery have been present with the electronic health record, which can make things easier. In hospitals, for example, at Columbia Presbyterian, using telemedicine and AI, they've been able to streamline the procedures in the emergency room and make things go much speedier. Johns Hopkins, as several of you know, has actually a command center which, using AI, has been able to streamline the movement within the hospital, managing the beds, the operating rooms, the flow surgeries. Same thing in other hospitals in the US, University of Pittsburgh, Dr. Geller is here, with uh, collaborating with companies, and that's important, uh, has placed a lot of focus in making things more streamlined. Now, in terms of the pattern recognition, they've seen in breast cancer uh, that you can actually get similar results to having radiologists look at digital mammography by having an AI system. And same thing has been seen in neurosurgery, whether intraoperatively using, again, the pattern picture recognition, you can get a quicker result. And the surgical decision program, whether you can actually identify people earlier in the process of considering what treatment options would be best for them. And this is all very important for us in liver surgery, both in terms of identifying the patients for resection, also for transplant, which is even more important. However, there are several traps or challenges here. For example, when they tried things for ICU triage at NYU, in the ICU, they saw some great results when they tested it, but when they tried to identify the single factor that would predict the biggest risk in terms of ending in the ICU, that came to be chaplain. Why? Because that's a word that in the records that actually ended up in the ICU and had a bad result, that was the most often frequently used word. So the fear of garbage in, garbage out is part of the risk involved. So in the cases of hepatic surgery and liver transplant, you have the possibility when you have the data that was used for criteria such as a MELD for different algorithms for us, when using artificial intelligence, you can actually have a much more specific system in terms of donor and recipient selection and matching. Also in using in robotic surgery, and this all started by the Army with DARPA, the Defense Advanced Research Projects Agency. The fact that we're now talking about 5G and telesurgery has made things, I don't know about easier, but certainly with a lot more potential. And that brings us also to CyberKnife. There's many more possibilities about more precisely, more targeted surgical interventions. And robots have been used in different ways as even assistants. However, what we have to differentiate is between a robot performing a surgery and a robot aiding in a surgery. Um, so this is very different between the two. And there is much more gradual learning involved if we want a more active role in the robot. Also, in terms of patient evaluation, collecting all this data can help us with categorizing with risk probabilities, especially in issues such as frailty, which appears to be playing an increasingly important role in hepatic and transplant surgery, but also in surgery in general. The nutritional status, different areas which can affect, with the whole goal being targeted therapy. Um, the question is whether we can come up better than the MELD. Also, in terms of the hepatic function, if there are certain research protocols ongoing where the idea is that if you can look at the picture of a liver and using that through AI algorithms, you can actually predict the quality of the liver. Again, this means that tons of data are involved to be able to make this come to these conclusions. Surgical oncology, as it's expanding its role in liver resection, liver transplantation, it's a field we're hearing more and more about. The patient selection involved is an area where AI is going to play a big role. And the whole goal is to, it's easy when you have a perfect donor and a perfect recipient, but the question is, well, to get a suitable donor for a suitable recipient. There are challenges. The first and biggest one is how to collect big data, how to keep it safe and secure, and how to use it best. There are several issues, such as the GDPR, for example, in Europe. There are legal issues. For example, if the AI system tells you you have to do a surgery, the type A surgery, but that seems unreasonable. Is there an obligation? How do you deal with things like that? And of course, who owns the data and its use? It is a business that's not the fact that several big companies such as GE, Google have been involved and are involved and want to be involved as part of it. And of course, the question is whether we're talking about a simulation or adaptation, something similar to the Borg and Star Trek for those who are fans. But the idea is that you're actually not talking about you're not going to lose the human element. We just have to learn about it, know its limitations, and know how to use it best. The overall goal is to have better navigation in hepatobiliary surgery. And these are some of the easier ways that you see here, the ultrasound, Metasor, the Pathfinder, and some of them have been used. Some of them have sounded good, but actually not survived practice, such as the Pathfinder as much. And ideally, you'll have the surgeon being able, either whether it's 3D visualizations, 3D printing, or augmented reality, to be able to plan preoperatively the surgery so it can be a more guided approach. This work from AirCAD, which basically they're doing, being able to see the geography of the tumor with the vessels on top of the liver. And HoloLens, which is Microsoft's take on augmented reality, it uses different sensors and advanced optics to meld with the environment. So by blending both the real world and the simulated or virtual one, you are able to potentially have more safety. What is the future? The future is combining a lot of these things. So combining the 3D printing possibilities together with deep learning and quantum computing so that you can actually use the data more in a more focused way, and then move towards the bioprinting issue, where you can have genetic algorithms with DNA, RNA sequencing, and using extremely large amounts of data to build more accurate models. So the big lessons here, this is ending, is that cross-disciplinary collaboration is key. We have to learn from engineers, we have to learn from biomedical technology, we have to figure out what it is, understand it, and be able to use it, because it's going to make surgery safer, more focused, and it's going to move us to the future. We don't have to be afraid of technology, but we also have to be strict about evaluating it. It doesn't mean that something is new is also good. And finally, we have to remember that technology is not a substitute for proper technique. Technology is not going to make the surgeon. And if we can find ways to help those that may not have the being as close to technology as we are, that can be also very critical. Thank you very much.